have Dr. Jessica Rohr and Mitali Paul from Houston Methodist to discuss the importance in understanding and advocating women's behavioral health. Dr. Rohr is a board-certified clinical psychologist with an additional certification in perinatal mental health. Dr. Rohr is dedicated to growing clinical research and training efforts toward the improvement of women's mental health. Her current research efforts are focused on improving perinatal mental health for women with trauma histories and women who experience persistent disparities. Mitali Paul is administrator with the Department of Surgery at Houston Methodist. Mitali is also adjunct faculty at Texas Women's University and instructor for the Physician Leadership and Management Certificate Program for University of Houston Clear Lake. She is passionate about leadership and women's health issues. And I'm so excited to talk to them today because it's so important. We're talking about women's health and covering a lot of things today. And, it's going to be a great episode, and I'm so glad people are tuned in today and, will be listening because it's going to help us really understand what behavioral health is and why it is so important. So good morning and welcome to Chat Time.
Good morning. Thank you.
I love this energy going on here. We were talking about the Super Bowl earlier. So we want to, of course, before we start the show, congratulate the Eagles for a great game. It was really awesome. Yeah. Although I know a lot of people wanted Chiefs, at least my side of the family.
I know, we're sorry for the Chiefs, but you can't deny that the Eagles really earned the win, so.
Yes, absolutely. All right, so let's begin with, about women's behavioral health. Mm-hmm. First, can we start with the definition of it? What is women's behavioral health?
So I tend to think about two kind of major factors that go into women's behavioral health. So one is going to be the your things you would diagnose: depression, anxiety, PTSD. Any of these diagnosable pathologies tend to impact women more than men. Even after a trauma, if a man and a woman experience the same trauma, women are twice as likely to develop PTSD after. And so there's those kind of issues where there's a mental health disorder that we in our book have listed as a disorder. And then there's also what I call normative stressors. So just sort of the difficulties of existing in the world that uniquely impact women. So these are going to be things like increased burden of caregiving, increased the hormonal transitions that occur throughout our life that many of us are not prepared for, difficulties of pregnancy. And so there are differences between men and women from a molecular level all the way up through biological, cellular, and then social, how we're treated and how we engage in society. And so behavioral health for women is specifically things that have to deal with our emotions, how we feel, how we approach the world, that might be impacting our functioning and just how we feel while we're trying to live, more than it may do so for men.
Okay. Mm-hmm. So why is it important for us to talk about it, and why is it important for us to even advocate for it?
So one of the things that we don't realize is that women are the backbone for society in any country, anywhere in the world. When you look at the World Health Organization statistics, women, when you look at health statistics across different countries, whether it's maternal mortality, whether it's, women's health issues, most of the underdeveloped or undeveloped countries really have poor women's health statistics and lots more women's health issues. And, as Jessica mentioned, women are prone to have higher likelihood of having mental health issues. 1 in 5 women are going to experience mental health issues in a year, versus for men it is 1 in 8. And then almost over 90% of women are going to experience some form of postpartum depression or anxiety. And when you think about that, it impacts not just the woman, but the health of the child as well, because that's the primary caregiver. And as Jessica mentioned, a lot of times women are the caregivers in their families, whether it's for aging parents or whether it's for children. So if we don't take care of women's mental health, then indirectly you're actually impacting the the health of the entire family or society in general, because that's kind of the greater impact that we got to think about. And one last point I'll make is, why is it more important now? And obviously Jessica will talk a lot more about it, but the reason it's so important now is we're still a few years away coming out of the pandemic. And what we don't realize is that there have been so many undiagnosed or underdiagnosed mental health issues coming out of the pandemic. And we just have so much of demand and not enough supply of experts like Jessica or like other mental health professionals, that a lot of people, especially women, will put their needs on hold. If my child or my parent needs health care, I'm going to be more prone to taking them to where they need help, rather than focusing from time off from work or focusing on my needs and my priorities. So women also tend to put their priorities on hold to take care of others, and then the problem exaggerates and gets worse. And so these are all the reasons why, everyone, it's not just women that need to be supporting other women's mental health issues. As a society, we need to be able to make sure that we're taking care of women, because it has a much larger scale.
Yeah, and I'm so glad we are talking about this, because I know when I mentioned to you, Mitali, that I really want to focus on women's health, because that is so important. We, when I'm in the restaurant and I talk to customers, and especially women, the topic is always about their family. It's about their kids, their husband, their work, right? But it's never about health. It's not about themselves. And it's just taken for granted, I guess. And as women, we have to take that step. We need to move forward and say, I'm going to take care of myself first before I can take care of everybody else. And I think that has to change, right? Like, our mindset has to change. And this is a great starting point to kind of talk about it. Yeah.
And I think we really have to position that that experience, because that is such a shared experience of we already tend to identify ourselves in terms of our relationships. I'm a mother, I'm a daughter, I'm a sister, I'm a friend. And that is rooted in kind of the societal push to do that, to decenter ourselves, to make ourselves lesser than what we can provide for other people. And there's a really, and I can go off on a soapbox about this, and I was telling her at the beginning, but I think it's really important to know the history of how we got to this point with women's health research, and how we are, because we very much are behind in women's health research as compared to men's health research. And that there are some really important reasons for that. I don't know if we want to get into that now or later, but I can go off. Yeah. Y'all, this is so interesting to me. And I present on it as much as I can, because I want it to be clear that it's not just that we need to specifically look at the unique things that women have to deal with, but that we are just behind significantly, to the point where there are medicines that have been pulled from market because they differentially impact women in a hurtful way, and that was only found out until the medicines went to market. Women were dying at increased rates. And so there's this long chain of events. So I've brought it down to 3. The first thing that happened in the 70s, do people remember the thalidomide trials? Does that sound familiar? So thalidomide was a medication that was being trialed for morning sickness in women. So it was given to pregnant women, and it led to significant birth defects and increased rate of fetal and infant mortality. It was a horrible, horrible tragedy. In response, the FDA said no more women of childbearing age in clinical trials. Just done in the late 70s. Women of childbearing age, if they were on birth control, if they weren't having a sexual relationship with somebody, if they were gay, didn't matter. If you had the capacity to become pregnant, which is for adult women from 18 until you hit menopause, you were not allowed to be in clinical trials. That was not changed until the mid 90s, when people looked around and said, hey, we don't have any research on women right now. Women are not in our trials. Women, it was easier for researchers to just say, well, let's skip women altogether. So that was, during that time, the internet was invented. Birth controls were being developed, birth control pills were being developed, diabetes medication. I mean, so many clinical advances occurred without women involved in the preclinical and clinical trials. And we still see the downstream effect of that. Digoxin was a medication, a heart medication that was prescribed for decades. And I called my mom to talk to her about this. She's a nurse. And I said, women were dying were twice as likely to die as men were when given this very common medication. So they said, you got to stop giving this to women. After decades of giving it to women.
Wow.
And she said, well, I gave that all the time when I was nursing. And I said, I know, these are things that happen. So we're playing catch up from that. The second piece is, for the longest time, until the 2010s, when the big research institute, NIH, said, y'all gotta stop doing this, researchers who did preclinical trials with animals, they do trials with rats and mice and other animals, were only doing them on male animals because the estrus, which is what we call menstruation, messed everything up. It was confusing. They go through estrus, so it's a little confusing, and then we have to have twice as many animals to make up for this additional variable, so we're just going to test it on boys. And so then by the time those animals went, or by the time those medications went to human trials, there was this whole series of issues that would come up that they had no idea about because they had never even looked at it in female. So there's that piece, the biological piece. And so clinical trials, it's really funny. This is one that I love a lot, and I hope that this is appropriate. But there is a medication for female arousal, kind of like the little blue pill, but for women, the little pink pill. One of their clinical trials was looking to see the interactions between that medicine and alcohol. It was they tested it in 95% men.
What?
A pill for female.
What?
So it's silly and it's terrifying. It's unbelievable.
Yeah.
So then the third piece of the puzzle is just the fact that women have just not been in the position to be conducting the research to begin with. We for the longest time, to do research, you needed to be on tenure track, which is producing and publishing through your 20s and 30s, which also happens to be when you're supposed to be having babies. And so women often were just kind of, they went to like a lecturer role. So I'm not going to produce, I'm going to teach because that makes more sense. I want to commit this time. And it's sad to say it, but we do what's called me-search. People do research on things that matter to them.
Absolutely.
And then we also think about things differently in research. It's not just who's thinking of the research ideas. So like again, I told you I was going to go on and on. The COVID vaccine. They had about 50-50 men and women in the vaccine trials.
Okay.
They did not ask women about their menstrual cycles. So then when the vaccine rolled out, we had some vaccine hesitancy because people noticed it delayed their menstrual cycle a couple of days.
Okay.
So people were worried, is this going to impact my reproductive health? I'm trying to have babies. What should I do? If they just asked that in the trials, we would know it does impact it. About one cycle, couple of days. We don't see any long-lasting effects. But if women are involved in creating the research, they don't know to ask those questions.
Right.
And they don't know to, say, offer compensation for childcare while you're participating in research. That's something I still don't see. How are we supposed to get women to come into research when they're caring for their ailing parents and caring for their kids? So there's a three kind of part that means that we are just behind. And so on my sad days, I think, and on my more optimistic days, I think, God, we have so much we can do.
Yeah.
Just small steps that will actually make a really big difference because we're just not where we need to be. And so for those reasons, it's not they're the very true, profound, and it's the right thing to do reasons to attend to women's behavioral health, and the fact that factually we're behind and we need to move up to where we should be.
And we're doing just that today by talking about
And
it.
this is a huge part of
Because there were things about the clinical trials that you mentioned that I did not know about, which is scary, which is very disturbing, but also, it makes sense. I mean, we just haven't had women participate. And so, we need to be able to support
Yeah,
more
they-
research
yeah,
in that
get the
area.
knowledge for sure. Because
Yes.
I mean, y'all are in the medical field, so y'all have that firsthand on everything, right? Most of the information and all. But for all of us, we are just like our expression is just shock, right?
Yeah,
Like,
yeah.
we don't because. In our minds, we think, okay, if they're doing any kind of a research work, it's always, if it's for a woman, it'll be-
Representation, yeah.
exactly, it's
Yeah.
going to be that way. It's not going to be like what Dr. Rohr just mentioned. Shocking.
Shocking. It is shocking. And that's why a lot of what my drive has been in my position is community education, because so much of this, even if we get away from the research piece and just thinking about our education about how our bodies work and what hormones are changing during our cycle, and most of the education about, let's say, puberty and menstruation for girls is all about hygiene. How to keep it clean, how to keep it hidden. They don't talk about what's happening with your hormones. Why does the first half of your cycle feel different from the second half? And that is, people are learning more about that now, but I'll put up a chart in a talk with just a very simple, estrogen comes up here, you ovulate, and then progesterone comes up. And I'll have women in their 50s and 60s taking pictures of it because they've never heard it before.
Yep.
And it's very important information for us to understand how we work individually,
Absolutely.
and engage with our world.
Yeah. So I'm just curious, do the schools teach that too? Yeah.
What do
Not
they teach?
to
Do
that
you know?
detail, though.
In fact, I received a letter today. It's yesterday that she was going to be participating. She's 11 now.
Okay.
And she's a 5th grader. So she will be participating in a class where they teach about body changes.
Okay.
Puberty. Yeah. That's about
Okay.
it.
Okay.
Those
It'll
are the
be
two that
interesting
they
to
cover.
see what content is covered, you know, because a lot of times, like you said, the details and the devil is in the details, because until and unless you understand yourself, to be able to even explain your symptoms or explain to a professional what you're going through. First of all, there's the stigma attached to it, right?
absolutely.
We don't want to talk about mental health issues because then it becomes like, oh, wow. I mean, and then what really makes me sad is that I work in healthcare, obviously, and I see some of my physicians that are suffering from mental health issues, but they don't want to talk about it because they're also concerned that you're going to question their capability of doing their
Yes.
jobs and performing in their roles. I'm pretty sure even for you, Jessica, for you to admit that you need help when you're actually providing help to other people, there's going to be that hesitation of saying, I'm a mental health professional. How is someone going to trust me to take care of, their needs if I come out and admit that I'm struggling myself, And most therapists have therapists.
Yes, that is. I was going to say there is a little bit, but we are pretty comfortable. We're pretty comfortable. I mean, and then part of it is because we do heal. I mean, I'll say often. I'll say this to my husband. He's an engineer, and he, it's the end of the day, and he wants to chat. And I'm like, I spent 6 hours listening to the worst things that have happened in people's lives today. I know. I just want to read my dumb book for like 10 minutes. And so there is. I think mental health professionals have that added, we get to say, I listen to traumas all day. That's hard for me. But a lot of physicians, I work with the OBs, and there is this tough dichotomy with them where I think people see OBs as having this really wonderful, amazing job. They get to
Yes.
deliver babies, and they're involved in the miracle of life. And that is true, and it is constantly traumatic for them because hard things happen all the time. They're sitting with, and they don't have, a ton of mental health training.
Yep.
And they're sitting with women and sometimes the worst days of their lives. And so that is a really tough piece of this, is how do I, especially as a woman, when as a woman, you're supposed to show up to work 10 times better, 10 times more productive, 10 times, and admit, and this is really hard. This is getting to me.
Yeah, yeah. And, it was interesting when we talk about how men and women are different in dealing with mental health issues. Of course, neurologically, and our brains are wired differently. But I didn't know testosterone was also an antidepressant or has antidepressant qualities. And I'm like, this is just so unfair. Like, we're doomed from every angle. Like, we got to still have eating disorders because we're trying to look a certain way. There's all of the stereotypes and the gender pressures that you feel as a woman. On top of that, even your anatomy is not with you in terms of, not only do you have hormones that make you feel low, now men actually have a hormone that helps them not feel low and be oblivious. I mean, that's just wrong.
I think that's definitely a place I go to a lot of the time. And as I'm learning more about how our bodies work, I am starting, I'll joke with my children that I'm a witch. And they love it. They love it. And with me, I told them before I accidentally dyed my hair green this weekend. And so that's my husband goes, it's just sort of your
Your
witch
natural
thing.
is coming out.
I said, I made y'all. I made y'all. That's magic. I'm a witch. My body changes, and I have energy and ideas, and then I'm more in tune and thoughtful, and I can smell things differently at different points of the month, and I notice things differently, and it feels, again, on sad days, it's like testosterone, and then on the good days, it's really, really remarkable. And there's actually research that says, and this is the thing that I get frustrated about in society, is how much we are made to question and look down upon the things that make women really magical and amazing. And in some countries where aging is celebrated and you're seen as wise, and it's an honor to age, and you're looked at as like women have fewer menopausal symptoms that are distressing. You literally have better health when who you are and what you go through naturally is celebrated, as opposed to here, anti-aging this. It's a war on aging. We're fighting aging. You have to look young. I've got Botox. I've succumbed to it as well. And it's a really interesting kind of point of how much of this is how I'm supposed to feel about this versus it's an honor to age. A lot of people don't get to age, but we're supposed to do it a certain way, which makes it a little bit harder.
Yeah.
Interesting. We got to change that. We got to change.
And I think in the schools is kind of one of the places to do it. That starting from the beginning. I've talked. My daughters know what tampon. Like I've talked to them up from the beginning about this is our bodies change, and some of it's hard, but some of it, if you know what to do with it, can be really, really kind of cool. And it's definitely going to take a tidal wave of change to do it, but this is a step.
I have a story to share. So both me and my husband got our physicals, right? So when his result came, he was tested for testosterone and everything, but I wasn't, like, on my physical, my blood work, I wasn't tested for any hormones. And I had asked my doctor, like, last year that, I think I'm going through some symptoms of perimenopause because I can feel it different during my cycle. She's like, you're too young. But then why was my husband tested and I wasn't? So I'm going to call the office. How come? Because the insurance covers it apparently for him, so they should cover it for me as well.
Yeah.
So, and I'm glad you're bringing this up. But now I'm just getting more
upset. I know. That's usually
Maybe it's the hormones. It's the hormones that are making you upset.
Embrace it. There is this piece of the three things I was talking about, where when you don't have appropriate research, the trickle down of that is incredible. So there's the trickle down into clinical education, where doctors are literally not educated. I can't remember, it's something like 78% of family medicine doctors did not feel equipped to deal with menopause. God willing, we're all going to go through menopause. That is not a niche event.
Absolutely.
That is more common than pregnant. More women will go through menopause than pregnancy. And so there is a piece of it that is just, you're going to be in the position of advocating for those things, which sometimes feels really uncomfortable. We're not used to doing that.
And I think that's one of the other reasons why you see the disparity between men and women's healthcare, whether it's mental health, behavioral health, or physical health. It's because men are more prone to advocate for themselves versus women don't, right? And that is a question that you would ask. And again, not to diss your primary care doctor, they don't know what they don't know. And, especially in women's health area, as Jessica mentioned, the research is so little, and we just don't have enough advances or enough information to even know what's out there and what's not out there. I, on the other hand, have been experiencing perimenopausal symptoms for the past 4 or 5 years. And, most of the women I've talked to, it starts in the early 40s. And you can have it for about 10 to 12 years before you actually hit menopause. And that's not an urban legend or an urban myth. That's a fact.
Yes.
Most women that I, have spoken to about this have experienced it late 30s, early 40s, it starts. So for someone to say, oh, you're too young, no, because you can experience those symptoms. And if you don't know, then you're again dealing with inconvenience, and sometimes it can get worse because it's a plethora of things. There's physical changes happening in your body, there's changes hormonally, mentally, and you won't even have an explanation of what's going on if you don't know, right?
Yeah, exactly.
Yeah. Yeah.
But I wouldn't have the guts to talk to my doctor saying, why am I not getting tested, or
Why not?
But because we're having this conversation, you know that there is a disparity, and I would not bring it up, but I would request it or be persistent about
Yeah.
it.
I have changed doctors, okay?
That's what
I have changed doctors sometimes when I don't feel I'm being heard or seen or what have you. And there is a lot of gender disparity in advocacy for women's health, and you always have to be, even for your kids, right? You do that for your kids anyways. Why not for yourself? Wouldn't you be questioning anything that, your kids are going through? So why wouldn't you question something?
That's the conversation, right? I'll be a mama bear for my kids, right?
Yeah.
Every day.
When
Yeah.
it comes to me, I just
Yep.
Yeah.
I'm just gonna be
Yeah.
sitting in the back, right?
Yep,
So
absolutely.
I didn't realize that's a lot of women out there.
Yes.
Who do
Yeah.
that.
Yeah.
Yeah, absolutely. Yeah.
That's why I love this conversation.
Yeah. Now, right after this, she's going to be calling her PCP like, I'm coming in for my TSH.
We're gonna get a break. I'm gonna make a call.
You better test my thyroid right now.
While you're at it, check cholesterol.
All right, so let's go on a short break, and when we return, we will continue this really incredible conversation. This is Chai Time, 103.5 Hum FM. Welcome back to Chai Time on 103.5 Hum FM. I am in conversation with Mitali Paul and Dr. Rohr, and we have been talking about women's behavioral health. It's been quite an eye-opener conversation, and a lot of things that has given us aha moments for us girls here, for us Chai Time girls here, for sure. So let's continue with this discussion. Dr. Rohr, what are 3 top behavioral health issues that you see in your practice women deal with?
So I tend to work primarily with moms and women in the perinatal period. So that's pregnancy and postpartum. So what I see a lot of, honestly, the number one issue I see is anxiety. And postpartum anxiety is actually more common than postpartum depression. We are just now, again, like we said earlier, we're just now learning about how profound it really is. And that looks like, constantly checking the baby, being really nervous during baths or when you're walking, holding them, starting to avoid doing things because you're worried you're going to hurt them. And that can even start to look a little more like postpartum OCD, which again is even more common in the perinatal period than it is in the general population. So see a lot of anxiety, and it's a lot of ruminative thoughts, which means thoughts just running all day. And a lot of it, again, is reinforced societally because women are holding so much all the time. They're doing so much of the mental load of managing a household. And it is reinforced to be constantly thinking, oh my gosh, I forgot to write down. So they'll get these little rewards of, see, it's good that my mind was running because I remembered something I would have forgotten otherwise. And that's tough to break that cycle. So definitely things in the anxiety realm, generalized anxiety disorder, which is just what it sounds like. I'm just anxious kind of about everything. And a lot of depression. People are really sad. People are really still isolated after COVID, lost friendships with COVID, weren't able to really just leaned into their families and taking care of their families, not themselves. And a lot of post-trauma symptomatology. So traumas that they thought were resolved from childhood that pop back up again when having kids. I thought I was okay with what my mom and dad did, but now that I have kids and I have this love for my children, I don't understand it anymore. and trauma just during pregnancy. We'll see some PTSD from pregnancy. So those are really the three big things I see in my practice.
Something to add to that, Mitali?
Not really. I think, that's kind of from a clinical perspective, those are the key things that you would see. One of the things when you look at society in general and what's happening in the world, sadly, another trend that we've been seeing is war, civil unrest across the world. And one of women and children tend to be the most impacted by sexual violence, by violence in general, and all of the trauma that they go through and the PTSD that comes with it. That's another reason that you see, women's mental health statistics across the world is much, much worse than men. Because that's where you see most of the sexual violence that's happening across the globe. Even over this weekend, I was reading in the Congo Democratic Republic, there were 165 women prison mates that were raped. I mean, when you see everything that's happening across the globe, most of that violence is directed towards, perpetrated towards women. Yes. And so all of that obviously has a toll on their mental health and how they recover. And do they have the resources? And that brings us kind of to the topic of access to mental health resources, to behavioral health resources, not just in the U.S. Access is very, very limited across the world, across the globe. And here, especially in the U.S., we have a severe shortage, and it's gotten much, much worse after COVID because people that were kind of sort of able to lead a normal life and didn't deal with mental health issues or anxiety or what have you are now, coming out and getting more diagnosed. Men are more likely to get diagnosed than women because they are, again, advocating for their own health and going out and talking to healthcare providers about their issues versus women are prioritizing their family's health and their children's health and not necessarily asking the right questions and seeking help. And then there's just the shortage of healthcare providers. I mean, a lot of healthcare providers got burnt out. We talked about, physician burnout, but that burnout is in other healthcare providers as well. We just don't have enough mental health providers in the country to provide the support and the needs that our population have. And then we'll talk a little bit about disparities and the more underprivileged, underinsured or uninsured populations you belong to, or if you are of a diverse background, then your access to healthcare goes down even lower. And physical health always takes priority over behavioral health or mental health because at least with physical health it's impacting your ability to work, it's impacting your ability, even though with mental health it could impact your ability to work, but you could still drag yourself to work. Physically, if you're sick, you can't go to work. And so again, in the priority of resources, mental health or behavioral health really comes down at the bottom in terms of access, in terms of just people even being able to access or having the resources. So it's important to be addressing these.
And one of the things that happens when mental and behavioral health are put at the bottom is that people often aren't seeking help until it's urgent or an emergency. So we're not getting in at a time when like a lower level of care or even a conversation or a book or a website, a forum with friends maybe would have had a different impact a year ago, 6 months ago, to just be told, like as a pregnant woman, it's okay that you're scared. That doesn't mean that you're going to be a bad mom. But if you keep that inside and it festers and grows and you start gathering all this information, then in a year, you need a psychiatrist and a psychologist. You need it now. You need a high level of care. And then it's hard to find. It's hard to access. It becomes this sort of revolving door effect where everyone has to get in. Everyone's urgent. And we just don't have enough people to serve that level of acuity. And that's one of the things that's been kind of tough is trying to figure out how do we change that and make mental health more integrated into physical health, so that it is a constant kind of, we're working on those on that stigma, and we're working on people's knowledge of their bodies and understanding of what they're experiencing, so they can speak up sooner and hopefully get a lower level of care that's more effective, more accessible. It's hard to go. I had severe postpartum depression with my first, and I knew that if I told somebody, they would want me to go to therapy once a week, because I was a psychologist and I know that you're supposed to go to therapy once a week, and I knew I wouldn't do it. I knew I was already feeling so bad about how I was as a mother, who I was as a mother. I couldn't fathom also going to therapy and leaving my child somewhere to prove further to myself that I couldn't handle it.
Yep.
So there's a lot there that I think we need to really address in terms of the system that mental health is kind of being addressed in.
You know, and I was looking at some statistics. I always like to look at numbers because it kind of delivers the message. So more than 40,000 Americans die annually from suicide. Okay? But in 2022, that jumped up to 49,000.
Wow.
Now, why was 2022 special? COVID, right? So can you imagine, 9,000 more suicides in the country just post-COVID? And we're just in 2025, so we're still dealing with a lot of those issues. The other thing is, when you look at, we were talking about in Texas, about 12.6% of women reported experiencing depression during pregnancy, and about 15% experienced postpartum depression. So again, those numbers are for the population, for the size of our state, and those numbers when you think about it. And I wonder how many of these people actually sought out treatment and did something about it, right? And the long-lasting effect of it, because again, it's impacting your children, it's impacting your family. There's also research that, we always say that, yes, we're putting our mental health, kind of below our physical health in terms of our priorities. But if you're not, mentally healthy, then your physical health also suffers. And there's research, right, to support that cardiovascular health issues are much worse, because if you're not able to take care of yourself, your physical health is also going to deteriorate. So this notion of, I can deal with my mental health issues, I got to take care of my physical health first, is really, contradictory, because if you're not mentally okay, guess what? Not only is your physical health going to suffer, the people that you're taking care of, their health's going to suffer too, because now you're not able to take care of neither yourself nor the people around you.
And that, I want to go back to what you said about the difference between people with depression and who actually get into care. The steps that have to happen in our current medical system, in order to access care, we lose people every step of the way. So you have to be willing to tell a physician, they have to hear you and not say, no, you're too young. So they have to hear you. They have to be informed enough about mental health to know what it is you're dealing with. They have to know enough about the referral sources in the area to give you a solid referral source. I mean, I remember when I was given a referral list of lactation consultants, 9 out of the 10 of them were out of business, had moved. I mean, it was just... Then you have to be willing, in your depressed state, to call, go to the appointment, be convinced to take medication. There's an immense number of opportunities to lose somebody along the way, and so the percentage is actually quite low that actually get hooked up with that kind of traditional care. And that's where I think we can really innovate, is to change how that works. We have care that works, medicine plus psychotherapy, and then other just kind of, eating well and exercise, which is again a very privileged thing to say, just that it's not that easy. Help people feel better, but you got to get that information to people, and so that's where I think we could be really innovative, is in doing that differently.
The other concerning trend that I want to bring up, because we have people that obviously are parents, and we're all parents, and we're talking about our children, is that the incidence of depression amongst teens has magnified.
Yes.
Some of it is also education and awareness, which is great because now people have a word for it. They know why they're feeling crappy, and they can actually seek help. We all probably went through depression as teens or what have you, but you know, at least I know back in the day when I was growing up, I didn't know I was depressed. I wouldn't know if I was depressed or not. I probably just felt crappy and, you know, thought that's what my life was and never really sought help or whatever it is, right? Like, because I didn't know, and you don't know what you don't know. So now obviously the rate at which people are getting diagnosed, they're younger, a lot of depression amongst teens, which, you know, I'm happy that it's getting diagnosed, but it's concerning that it's starting younger. Girl teens, just like women, are twice as likely to be prone to depression. Girl teens are twice as likely than boy teens. That gender difference just percolates down to kids, right? So again,
what's really interesting is there's this great chart in one of the articles. Girls and boys have the same rates until puberty, and then girls. And so if you think about, and it'd be easy to blame hormones, but imagine what's happening during puberty. I mean, the things that are expected of women, the way you're expected to be. So yeah, that's pretty striking. And then it remains like that. Go ahead.
No, I'm glad you mentioned that. So that's another concerning trend to be, you know, worried about as well is, you know, we have to do away with the taboo of talking about it. We have to be having these conversations with our kids about emotions. Something that I'm learning from my sister, who's actually getting a degree in psychology. So she loves preaching. She loves preaching, right? Every conversation with her lasts an hour, and you know, she's diagnosing my neighbor or me or my kids or whatever. But you know, it's amazing how, you know, she was talking to my kids and she was doing something called the emotion chart, where she's like, you know, how many of these emotions do you recognize? And there were about 12 or 18 emotions. And most of us, even as adults, are probably more like anger, sadness, you know, jealousy, happiness, like 4 or 5. But there are actually 18 emotions or 12 emotions. I don't know.
Depending on the chart. I've seen charts with 50, 60. I mean, it is pretty, we are very complicated.
Yeah. So, you know, the spectrum of emotions and just the ability to even name your emotion is so powerful. It's so educational because it allows you to even express yourself, you know, and know what exactly is it you're feeling. Because if you don't even know what you're feeling, how are you even going to fix it or do anything about it, right? And so, I mean, it's again, it's so important for us, you know, to have these conversations and be more aware of what's out there, be more aware of the research, and understand how gender differences and, you know, ethnic disparities or ethnic differences or what have you, diverse, you know, for diverse populations, all of the conversation that we had today could have a completely different, you know, impact or connotation. And most populations experience mental health differently because of so many factors. You know, you have socioeconomic factors. Where you live, the zip code determines your physical health care as well as your mental health care.
And there's cultural differences, religious differences, and I don't know how much time we have because I definitely don't want to neglect that point of the disparities, the racial and ethnic disparities within women's behavioral health. But there are, and we're doing some of this research at Houston Methodist on looking at trying to better understand how different groups of women are engaging in care, expressing themselves. There is significant evidence that Asian women and Black women tend to experience and Hispanic women to a certain extent tend to experience their mental health concerns more somatically, which means in your body. So feeling headaches, stomach aches, chills, tingles, and that's more reflective of anxiety and depression. But we don't ask those questions. We ask very kind of white-centric questions in the postpartum and the period. I'm thinking perinatally, but in that period. And so I think we're missing a lot of people. And even my language just then, for the longest time, the research was really white versus non-white. And now we're starting to do more nuanced research, but even then, Asian is usually one big group, which, as we know, is very different. And so we're missing so much nuance and so much information by continuing to ignore the fact that we are having very different experiences based on our cultural experience and then how we're treated. And those are pieces that need to be, again, that we need to be really focusing on and advocating for, really fighting for, to be able to see what people are experiencing instead of, people sitting up in their ivory tower and saying, well, this is what's happening.
That's so true. And I also wanted to add that it's so important to have the support system. Like even amongst friends, right? Like we are saying we want to raise awareness, we want to address, but also when we gather around as friends, we go out for a cup of coffee, just to check in with each other, their emotions or what they're going through, and to be kind of like talk about it. So, like sometimes I'll check in with them and say, hey, what's going on? Or if I know something is, I have that feeling something is wrong or something, I'll just pick up the phone and say, hey, just checking in, or leave a message. And when you're ready, you can just call back and we can talk about it. So having that support system also is also like one of those key factors to, I mean, like learning about all of this also, but also getting that knowledge, but then also supporting someone who is maybe going through and does not know, who to go to or any kind of resources. We can help out in that way.
I would argue that it is the key factor, and that's what the research is saying over and
Yeah.
over again, that social support is the number one factor leading to resilience in these times. And I want to say one thing about that, because I hear it over and over again. If you are struggling and your friends are struggling and you think, I don't want to burden them with my struggles, which I hear every single day, but I have never heard I've been doing this for just 25, 15, 18 years now. I have never heard someone come in and say, my friend opened up to me and it burdened me. I've never heard a person say that, ever. But I hear it almost every day. I want to talk to them. I don't want to burden them. I'm supposed to be the caregiver. I'm supposed to be the one with it all together. But that is what emotional intimacy is made of, is sharing those things, being vulnerable with each other, supporting each other, knowing you're not taking it away, you're walking with them. And so I just wanted to take the opportunity to tell as many people that as possible, because I hear it all the time. And that's just what you said at the beginning. We women are trained. We think we are supposed to be strong. Strength is equated to lack of emotions or lack of which is just doesn't make any sense to me, because you're much stronger when you're carrying things than when you're not, obviously. But that is something that I have seen over and over again and want to say, social support. You nailed it. It is the key. It is the key.
And, I want to make a point about advocacy. When we talk about advocacy, we talked more in a personal sense, where you want to advocate for your health, but it's also important to talk to legislators, to talk to people that are making decisions, because most decisions are being made by white men, okay? And we all know this. And not to say it's right or wrong, but I loved what Jessica said. We do research, right? So you're making decisions based on what you know and the world that you live in. And even the most well-intentioned legislators are only going to see the world from the glasses that they're wearing, right? From the lenses that they're wearing. So if they're not a woman, they're not an Asian immigrant woman, they will never understand what unique needs an Asian immigrant woman has or a black woman has, and so we have to be able to advocate for more research for women, funding for more research. We have to be able to advocate for basic, decisions that we can make about our bodies. And I don't want to get into this very touchy topic, but I cannot not get into it because I feel so passionate about it. Politics should not be in healthcare. Our decision to take care of a woman, whether she's pregnant or not, or her decision to end a pregnancy, it's a very personal decision. And for, the government or for anybody else outside to be making those decisions and not having women at the table when those discussions are being made, to me, is almost a violation of your human rights.
It is a
And,
violation.
you know, I'm saying this out aloud, and, you know, you may or may not agree, but it doesn't have to be, you don't have to be polarized in being on one side of the aisle when it comes to basic human rights. You know, what is right, you got to fight for it. It doesn't matter who you vote for. It doesn't matter. And that's another thing that we've got to be able to advocate for is what is right. Our society rests on women, okay? We are the backbone. And if we're not well, if we are forced to have babies when we are not able to take care of them or physically are at harm, that's another thing. I mean, think about all of the trauma and mental health and PTSD that all these women that don't have access to that care are going to deal with for the rest of their lives, and the quality of life of the women, of the children that they're birthing. You know,
And the children they already have. I mean, many times these are, yes,
Yeah.
this is the trickle down effect is enormous, and we need to intervene.
Yeah,
So
definitely.
we've got to advocate. We've got to be able to speak up to legislators. You've got to, you know, start from your city, start from the state. I mean, every one of us has a voice. And there's absolutely no reason why we sit on the sidelines and let other people make decisions that impact our lives day to day, that impacts our neighbors, our friends. We've got to be able to speak up. And a lot of times, you know, even the most highly educated people, we're just staying quiet and letting our government legislators do the talking. Why? You know, it impacts us. So I would strongly encourage people to, you know, raise your voice,
Yes.
educate, you know, education, awareness, and then encouraging people, especially if you have somewhat of a powerful voice in your community, in your city, use it and encourage other people to speak up for what's right,
Yes.
you know?
Woo, what a great way
Sorry.
to end. Definitely had to get y'all back here. We just scratched the surface.
Yes, that is very true.
absolutely.
That is
So
very
definitely
true.
would love to revisit this, this discussion on women's behavioral health for sure. Thank you, ladies. Thank you so much for
Thank
joining
you
us
for
here on
having
Chai
us.
Time.
Thank you.
Truly
Yeah.
appreciate, the time spent with y'all. Yeah. Thank you.
Thank you.
Thank you, listeners, for spending this hour with us. If you are unable to join in the conversation on women's behavioral health, we do have it on our podcast, which is Chai Time Podcast. It's available on all podcast platforms, Apple Podcast, Spotify, iHeartRadio. So you cannot miss this really amazing conversation. And like I said, we just scratched the surface. We have a lot more to talk about. So thank you for tuning in. This is Chai Time, 103.5 Ham FM.